Good evening. My name is Marcus Calabro. I'm the Director of Sales and Marketing here at IECO, and I'm excited to be your host for tonight's episode of our continuing Dry Eye Patient Educational Series. I'd like to welcome everyone in our audience, and as in prior broadcasts, I encourage you to ask questions using the chat section on your screen. If you have any questions, please post them there, and our team will relay them to me a little later. But obviously, before we get started, of course, I'd like to thank our dry eye expert panelists who will be returning in September, so you won't want to miss that event. And of course, our guests tonight are ophthalmologist Dr. Nicole Lemanski and Director of Clinical Research, Mr. Brian Lemanski. They're from Dr. Mabel MP Cheng, MD, and Dr. Nicole Lemanski, MD, eye physicians and surgeons in Latham, New York. Their practice is one of just 37 nationwide that earned our Elite Dry Eye Award for their work in treating dry eye patients. Welcome, Nicole and Brian.
Hi, thank you for having us, Marcus.
Oh, my pleasure. So just so our audience has some background, when did dry eye become apparent in your practice?
So first, I'm a cornea and refractive surgeon. I also do comprehensive ophthalmology. I work actually with my mom, who's a comprehensive ophthalmologist as well. And Brian, who's actually my brother, it's a family practice, is our practice administrator and heads up the research division of our practice. So I think that, dry eye became most apparent to me actually even before I went into ophthalmology. When I was first starting my training, before we do our surgical training, we have to do both medicine and surgery. So I remember being on a rheumatology rotation, and the rheumatologist knew that I was going to be going into ophthalmology. So he took it upon himself to point out all of his patients who had very dry eyes and Sjogren's. And so what I realized, it was like almost every single patient.
Wow.
And then when I started my own ophthalmology training, I noticed that whatever clinic I was in, whether it was the glaucoma clinic, the cornea clinic, the retina clinic, people had those specific problems, but then they also had dry eye on their problem list. So it was became very real to me very quickly that this was a problem that, permeated all throughout all the specialties, and a lot of people suffer from it.
Interesting. What percentage of patients have moderate to severe dry eye, would you say?
Well, in my own practice, I'm a little biased because I see so many dry eye patients, and I receive consults for people who have maybe failed therapy or had trouble with treatments. So in my own practice, probably 85% of my patients have moderate to severe dry eye. In the United States alone, 16 million people are diagnosed with dry eye, and that's a lot of people. And you think of all the people that don't actually have the diagnosis. And worldwide, it's one of the major eye conditions that can really affect the vision, and people don't really think of it that much. And it's interesting because not everybody who has dry eye actually is symptomatic, and that can be a problem because one, they never go and get checked out, and two, unfortunately, they can have problems just with their vision, and they don't ever think that it's actually from dryness. So there's a lot of underdiagnosis of it as well.
Yeah, I know Brian and I spoke on the phone quite a few times about the work he's also doing on the clinical research side. And Brian, now you're the practice administrator as well, so you actually interact with many dry eye patients as well, correct?
Yeah, I do. That I do. And a lot of what I do on the back end of the equation is to take a look at the data that we have and try to make sure that is everyone getting the workup that they need. There's really a couple different flavors of dry eye, and it's really important to tailor what specifically that patient has, and to drill into that. I'll have you talk a little bit later about that. To really drill into that, we need a good combination of imaging technique. We need a good combination of both qualitative and quantitative analyses, and we can leverage the power of our EHR system, our electronic health record system. I've worked very closely with our EHR vendor to build out these modules where we can basically run these calculations behind the scene. And that helps to make a lot more informed decisions on the front end of the equation. So that way my staff know exactly what to do. It also helps the patient understand too what's going on. Since we use so many photos and all these modalities, we love showing patients exactly what's going on. I mean, I can show you a poster, but I find that it's much more meaningful. And I think we can all agree with that. It's much more meaningful when you see yourself and go from that into the equation. But I'll let her speak more to that.
That definitely helps. Definitely helps with compliance when somebody sees their own eye or they see their own imaging study.
Right.
Compare theirs to a normal, especially with the people who don't really believe you that they have dry eye, and then they can actually see and they're like, wow, okay, maybe I have to do something about that.
Yeah, very interesting. I know a little later we'll go over some of your practice's history, but at first, let's take a look at your first case study.
Okay, so this is a patient that had been in the practice for quite a long time. She's a 75-year-old nurse, and she had some fluctuating vision that bothered her throughout the day. She also had, she was saying her eyes were really itchy and she had some tearing, and she felt that it looked like she was crying all the time. So we brought her into the office. We did a tear lab, basically to check the osmolarity. The osmolarity of the tears can indicate if you're more dry or less dry. Basically, a higher number usually indicates that you're drier. We also did Meibomian gland imaging, which is, for those of you who've watched these series, you probably know a little bit about the Meibomian glands. We've got a picture up here. These are the oil glands that run in the tarsus. So this picture here you can actually see 4 eyelids here, and they're everted or flipped. So this is the bottom lid, and we kind of flip it, and we look with an infrared camera at these vertical glands. The top picture you can see is a normal lid with good Meibomian glands, these white kind of vertical lines, a little bit squiggly, but this person at the top has a normal gland appearance. You see the next one down from the top is somebody that has a little bit of dropout. That means that some of the glands have atrophied or have been damaged. Maybe they had a sty, and you can see these glands, are not as robust as the ones in the top. So maybe this person doesn't have as much oil in their tear film. These Meibomian glands basically work full time to put oil into the tear film. The tears are actually oil, water, and mucus. We don't always think about that, but with every blink of your eyes, a little bit of this meibum oil is supposed to come out, coat the surface of your eye, and then that makes it so the water part of your tears don't evaporate as quickly. And so that gives you better vision as a healthy ocular surface. As you lose the Meibomian glands, you have less oil, and then the tear film becomes basically the wrong concentration and can lead to issues with inflammation, discomfort, poor vision. You'll notice that the second to the bottom picture, this person with stage 3 Meibomian gland dropout, they have, in some cases over on the right, I wish I had a little pointer, but there's no glands there. And then you see exactly. Over right a little bit more. Those are definitely shortened. Yeah. And then
yes, right here. Yeah.
They don't have any glands there. And then the bottom picture is somebody who has almost no glands. There's a little tiny glands there. And interestingly, and I'll share this with you guys because I think that this is something that, so you know I'm being genuine here, but this is my lid on the bottom. So I suffer from dry eyes, and I have my Meibomian gland dropout. And, it can be caused by dryness, long-term allergies, long-term contact lens use. You can just have it genetically for whatever reason. So, this is one thing that hits home for me as well. And I think that, I'm always telling my patients that, this is important, and I can kind of understand what they're going through. So this lady had some dropout of her Meibomian glands. And she also had, so what we realized is, she really had not such a great ocular surface for a few reasons. She had kind of this allergy, itchy picture, and then she had this dryness because her oil glands were not as robust, and she wasn't having the right concentration of her tear film. And then she was beginning to feel it. So we can go back to that next one. Yep. So basically what we had her do, she had a few at-home therapies that we had her do first, which included the iEco Derm mask. Now, this is a really super easy mask to use. You just heat it in the microwave. We actually had her do that just to start out with. I use this myself. The Tranquilize is actually available as well if you have more, basically you have a longer duration of heat and a little bit more heat applied to the area on the closed lids. Hypochlorous acid spray kind of kills any bacteria. Avenova is one of many, and that's usually done 1 or 2 times a day. Hydro eye and omega-3 fatty acids are also recommended for this because they'll actually give those meibomian glands a little bit better quality oil to put on the surface of the eye. The DHA and the EPA are the better quality omega-3s, and that's what you really want to look for when you look for a by-mouth supplement of omega-3s. A lid hygiene routine is always really important. The above, what we talked about and what's on the slide really has to go with that, the warm compress and, the daily washing and then using the lid spray. This person also had enough inflammation that she needed some Restasis. You might have heard about that before. It's been around for a long time, cyclosporin. We use it for dryness and also for inflammation and just over-the-counter gel drops as well. We also told her, she had to take a little break from her computer use and then also to try a different type of makeup. Some of the makeups, mascaras, eyeliners, some of them will say ophthalmology tested, dermatology tested, hypoallergenic. We really encourage our patients to go for these makeups instead of ones that don't say that, and really remove all your makeup every night. It's all too easy not to do that. If that fails and you're doing all the at-home stuff, you can basically do a heated Meibomian expression, which is in the office. We use basically a machine that heats the lids. We do the upper and lower, and then after it's heated up, it doesn't hurt. It's actually quite comfortable to have done. You can express or squeeze the eyelids with a special little tool, and the backed up meibum will come out. And then after that, people will feel a lot better. So she went through all of these, and while it's not a quick recovery, a little bit every day goes a long way. And so her lids were a lot less puffy, her dry eyes were a lot more comfortable. So she was, a lot more comfortable and was seeing a lot better, and her symptoms resolved. She definitely gave us the, sometimes these list of regimens can be a little involved, and you have to really feel out whether you think a person can do all of this. And, for patients, I think it's important. If you think that your doctor is giving you too much stuff, you should say, you know what, I'm not sure I can do all of this. So we try to get a feel, and I talk to my patients as much as I can to see, what do I think they can realistically do? I don't want to give them a list and have them only do one of those things. We have to talk about, okay, do you think you could do this, 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 and this? All right, let's do that. And then when you come back, we'll see, once that's kind of your routine, then we can add more.
It's really interesting also. And at this point, we've done a few of these webisodes, and I'm curious to hear what people think in the chat. But it's incredible that, you're really a proponent of, the simple items first, and then you kind of take it from there, right? So I suppose, simplest solution that works best is kind of the name of this case study. Let's take a look at your second case study. I know that we want to get to some other things tonight. So tell us about patient number 2.
Yeah, so she'd been a long-term patient of my mom's actually for a while. She's been in practice for 30 years, 78-year-old female, and she was actually an electronic medical record sales rep. So she really had a lot of time on the computer. She really had a lot of fluctuation in her vision after cataract surgery. Even though she had a great outcome with her cataract surgery, she had a history of dry eye before her surgery, and then afterwards she was a little bit more dry. So when we looked at her tear lab osmolarity, her numbers were a little bit higher. On her Meibomian gland imaging, she had a little bit of dropout. And on her OPD wavefront scan, this is a scan that we have in the office, basically took a look at the regularity of the cornea, because we want to see, is the cornea normal? Because we want to see where her issues are coming from. But this is a really neat machine because it can also give us a lot of information about the ocular surface, and if the tears are good. There are a series of little rings that we can look at, and if the rings are not complete, it means usually that the patient's ocular surface may be dry. So basically she had a combination of dry eye that was both from Meibomian gland dysfunction and her tears evaporating too quickly, as well as CPAP use. So we found out a little bit later that she was actually using a CPAP for sleeping. And so that was blowing, air in her face every time, in her eyes during the night. Yeah. So she had basically a derm mask, which is the warm compress. Warm compress is like the baseline, I think, for all dry eye. This is like my favorite thing to give to people. It's easiest to do. It just takes a little bit of time from the patient, because what I realize, people end up not doing it because they can't check their email and look online and do Pinterest. Like when they're doing this, they have to close their eyes and take 10 minutes for themselves. So she was doing that. She also did Restasis, and she also did Hydro Eyes. At night, because she had the CPAP, she was using the eye seals, which is a great product from IECO. Basically, it's silicone, soft sleeping mask. It comes in all blacked out, or you can get clear if people don't like to be blacked out at night. And so it protects the ocular surface from the extra air from the CPAP. And she also used gel eye drops before applying the mask. We also recommended that she really had to take a break from the computer. And that's something that's very important, especially now in the era of COVID, when we're all working at home. So this patient was a lot happier. Definitely the CPAP mask helped her quite a bit.
Yeah, it's really amazing. I know both of these, when I first saw the case studies that obviously were submitted by your staff and by yourself. Sometimes we think like, oh, most patients are going to need an expensive procedure, or they're going to need an expensive piece of, a take home. Obviously, there are people, I know that many patients that have tried many different things, obviously they need it, but then there are other people that maybe they don't need it. And trying, especially with yourself and Brian and your mother, I love that you're able to kind of treat the wide gamut of dry eye patients out there. And of course, that's why your practice won the Elite Award from us. So I love these stories. I really do. So I'd like to, before I actually open it up to Q&A, I know that we have about 12 minutes left. I noticed an image on your website with the caption, something to the effect, training medical students from Albany Medical Center. So are you the doctor that trains other doctors?
Yeah, so I'm on staff. It's not just me. There's a lot of other, ophthalmologists who are on staff at the hospital. But we have a residency teaching program, and we also have a medical school at Albany Med. So there are certain things where we'll have training sessions with medical students, teaching them how to look at the optic nerve, do some physical exams that really anybody can learn how to do with the ophthalmoscope, and you don't even have to be an ophthalmologist. So some of the primary care doctors and people who aren't going into ophthalmology necessarily, still it's important that they know how to look at the eyes and kind of pick up when there's an issue or problem. So it's important to teach the medical students, and I do take trauma call with the residents. So it's usually doing some teaching when we're in the operating room in a situation where unfortunately they've either gotten hit in the eye or they've been in a big accident. But I enjoy that. It's really nice to be able to work with people, and they're super, super smart, and we're up late at night, but it's always kind of interesting. We have to problem solve on our feet. So it's a really, really good, it's a good experience. Yeah.
Now, just a quick question for Brian. I know I want to put you in the mix as well. And I know you've done the clinical work, and are you seeing any new dry eye trends in treatment, or on the clinical study side? Is there anything kind of new and up and coming that you can divulge, or?
So a lot of it is really getting to know who your population is. So normally we had traditionally thought of dry eye as being a older person's disease, whatever that actually means.
Right.
Couldn't be further from the truth. There's a lot more data, and then part of that had to do with the fact that the technology really to image Meibomian glands wasn't really accessible in the United States for quite a while. And I would say that probably changed around 2015, 2016. And we ourselves have a natural experiment going on where one of the school districts in our area has moved to Chromebooks, so they don't have any textbooks anymore, which is like kind of bizarre to me. And then one hasn't done that. And we can actually see a definitive change between the two populations. I'll tell you that the the folks that have transitioned over completely to Chromebook use and things of that nature, who use a lot of digital media, and I usually encourage people, especially parents who are in the audience, to keep track of how long your children's on a phone. Don't be surprised that that number is somewhere between 7 and 10 hours a day. It really is quite a bit. But those patients who are 10, 11, 12, 13 years old that are complaining about dry eye now, which is really quite striking to hear when you're talking to them.
Yeah.
They have Meibomian glands that look probably the same, if not worse, than some of them are 70 and 80-year-old patients. Wow. And so what we're finding is dry eye is really, the face of it is really changing, especially Meibomian gland dysfunction. Now that we understand that Meibomian gland dysfunction is responsible for something like, depending upon which branch of literature you read, 78 to 82% of dry eye symptoms. You have excessive evaporation brought about by loss of oil on the surface. Mm-hmm. That creates a whole bunch of problems, and that leads to elevated tear osmolarity, which then leads to the cycle of dry eye. Mm-hmm. And you have a lot of these people being affected really young. So there's a bunch of work being done right now on diagnosing the younger population, trying to figure out what to do with the younger population, because let's face it, we're not going to stop using our cell phones or our tablets.
Right.
It's very difficult to do that. And that's why we have these regimens and therapies in place, like the derm mask, because the literature is very clear about how much heat is needed. That's actually very well known. Mm-hmm. We know how much heat is needed. We know what kind of heat is needed. So we need warm, moist heat. And we know how long it has to be applied for to be efficacious. Mm-hmm. And so getting the young people built into their regimen there, we're trying to make sure that they preserve the remaining glandular function for as long as they can. There really isn't a way to do that. There's some work being done in regenerative medicine right now on trying to restore the Meibomian glands, but unfortunately, we're probably quite a ways away from it right now. So we have to work with what we got at this time. I'd say the other really big thing in dry eye space that's working there are slow eluting punctal plugs. So punctal plugs are things that you place in the puncta, which are areas where tears drain out of the eye. You have 2 on either side. And the idea is you put medication in there and it slowly elutes it out onto the ocular surface to help the ocular surface heal from sort of dry eye conditions. That's coming down the pipe. We're very excited about those slow elution techniques because it really frees the patient from being a slave to drops, so to speak. Wow. You know, it's a very liberating experience. Dry eye, like Dr. Lemanski was talking about, these regimens can sometimes be all-encompassing. And it's really important to consider the patient's quality of life, too. Mm-hmm. We don't want to give you a regimen that ends up taking your entire day to do. You know, that this is not attainable. So those are the big things right now. There's some revisiting of IPL, which Dr. Lemanski can talk about. And they're trying to re-explore that. And the heated manual expression portion of the equation, they're trying to establish more of a timeline for who are the best patients to target. So this long story short, the space is really exploding in terms of the type of drugs that we have, the treatments, and also the diagnostic capabilities. It's actually a very exciting time to be in this field.
Mm-hmm, mm-hmm. Yeah, I mean, I kind of equate it in my own life, you know, especially with COVID, you know, we do more Zoom calls, you know, we're on our phones, on our devices all the time. Here on the West Coast, you know, we're kind of starting to mask up again. So I know that there's, you know, some forced air, as they say. I think they're referred to as masked associated dry eye. So I know that this comes up pretty often. How do patients find out more about setting up an appointment with you? Obviously, those that are in upper state New York, where you're at, but if anybody nationally wanted to find out more about your practice, where would they go?
So you can go right to our website. It's www.mabelchengmd.com. I think it's on the page where you register for this as well.
Okay. Great.
And you can just Google our names also. If you lost that link or whatever, you can just Google either myself or Dr. Cheng, and you'll be able to find us. We may come up on the listing as Niskayuna, New York, which is, we're right on the border of Latham. We usually say Latham because it's the easier of the two. but we're in upstate New York, not too far outside of Albany, and we're more than happy to, we always welcome new patients, and we're more than happy to talk to you, definitely, and make an appointment.
Okay. Fair enough. Yeah. Now I know a little bit earlier we talked about kind of the family practice. Tell me a little bit about how you got involved. I mean, of course, your mother, you said, is an MD.
My mom's an ophthalmologist, and she's had a private practice since 1999. So, both of us grew up and saw her, setting up her practice, and just like in any other branch of medicine, if you're a one-person show, you're doing a lot of work. Mm-hmm. And I think both of us worked in the office when we were younger, so we kind of saw her set that up, and I think that I saw a really good opportunity. It's really amazing to be able to work with a parent or a relative, and to work with your mom, who's also a surgeon. I mean, I follow her in the operating room, and it's pretty cool. If I get there early, I get to watch my mom operate, and she's an amazing surgeon. And everybody always thinks it's cute when I'm going into the OR and watching her. But I mean, it is pretty cool because it's your mom, and she's doing some cool surgery in there. So, and it's great she's a great mentor. She's a very smart person, really, really hard worker. So it's really good. She's always been a role model for me. And, Brian too, I mean, he's like super smart and can multitask at the wazoo. And he does all kinds of research, and he presents at the academy. So he really keeps us in the loop and pushes us to do research, which we really like to do. And we do a lot of clinical research, and he 3D prints, which is pretty neat. So all kinds of devices, and he's got some patents pending, which is really cool. So we have a lot of stuff going on at the office, and we enjoy each other's company. So we work well together. So it's a really good environment. We like it.
It's interesting because our mother, Dr. Cheng, was actually one of the first physicians in our area to bring Restasis to the patient population. Oh, wow. It was one of the first people to use low dose of steroids also to optimize the ocular surface. This was probably in like 2005.
She's been treating dry eye.
She's been doing this for a long time.
For a very long time, aggressively. She's got some long-term patients who have done great because of everything she's doing.
And I think she was also the first to bring osmolarity into the capital region, because she realized very, very early on that unless you measure and quantify these baselines for where people start, you really don't know where your therapy is going. You need to have a baseline, have some qualitative and quantitative data, and then reassess as treatment goes on. And those values have been really instilled in us, and it's such an inspiration to work with her. I really couldn't imagine any other place to be.
Yeah, and in fact, that brings up an interesting point, because obviously IECO, we encourage and really promote patients to visit their eye care professionals for proper diagnosis. There's a lot of products out there. There's a lot of companies. It's easy to read an advertisement or look at a video on YouTube and think like, oh, that might work for me. But we really encourage patients to go out and talk to an eye care professional. Obviously, one that specializes in dry eye. And I just can't thank you enough, Dr. Lemanski and Brian, for being a part of our series. I want to thank everybody who watched live, and of course will watch our replay. And again, I just encourage everyone to visit their eye care professional and get a proper diagnosis. And of course, if you need more information about Dr. Lemanski and the practice, please reach out to them as well. You can always reach out to us, and we'll give you the information. Thank you so much again, and please stay tuned for upcoming live events, and we will see you next time. Bye-bye.
Thank you. We also have a Facebook and an Instagram, so you can check us out there.
Yeah, and I definitely want you to do that. Go ahead and it's just Dr. Mabel Cheng.
Yeah. Okay. I think the Facebook is the same as our practice name, and then the Instagram, I think is, I think somebody had, I think actually the Instagram is dr.nicole.lemanski.
Okay.
And so, and I have a Facebook as well as Dr. Nicole Lemanski.
Oh, okay.
Apparently,
Great.
we tried to make it exactly the same, and like,
It's always, isn't that funny how it works? It's hard to get them to all line up.
But you can Google us and you'll see us.
That's how you do it. Okay. Well, everybody, thank you so much for joining us. We'll see you next time, and have a wonderful weekend.
Bye-bye. Thank you, everybody.
Take care.